everyone. Welcome to Dr. Deepa's Learning Launch. Today we will be discussing hepatoblastoma, which was a case that I shared with you guys last week. So we will look at the entire pathology. We will look at the morphological patterns. We will look at the IHC staging, differential diagnosis, the clinical aspects that every pathologist should know before reporting it out, because you need to converse with the clinical side also. And I will also be telling you the prognostic factors, which are very, very important for hepatoblastoma. So first, let me show you the whole slide image that I sent to you last week. So this was the diagnosis of this case was hepatoblastoma. You're clearly able to see this was a 2-year-old child with a liver mass, and this was a hepatoblastoma case which I had shared with you. So today, without much ado, I just wanted to discuss hepatoblastoma in detail. So rather than simply memorizing the different patterns and the importance of each of the pattern, I wanted to do a discussion on an integrated manner. So I took a little bit of time rather than creating an infographic for you and putting it up with the WhatsApp group. So we start in the clinical setting. We will look at the pathogenesis. We will move to the gross pathology, the microscopic pathology today. And most importantly, we will have a discussion on recognizing the fetal, embryonal, and small cell patterns and the various other rare patterns. We will then discuss the role of beta-catenin, then glypican, hepar, and we will look at glutamine synthesis, and we followed by an important differential diagnosis, particularly from hepatocellular carcinoma and small round blue cell tumors. How do you differentiate them? Finally, we will also be looking at the pretext staging, which is very, very important for the pre-treatment staging of the hepatoblastoma tumors. And the key message of this is that hepatoblastoma is not just a microscopic appearance. You need to have a holistic approach for diagnosis of hepatoblastoma. And the tumor actually recapitulates the entire different stages and patterns of a developing liver. So that makes it all the more difficult, because it usually occurs in a child who is otherwise developing the liver by itself, and you have a tumor that recapitulates the development. So it is a little tougher at a younger age group. So by definition, hepatoblastoma is considered to be predominantly a pediatric malignant liver tumor that resembles a developing fetal or embryonal liver. So the concept is extremely useful, because while looking at the microscope, instead of asking only why does the tumor look, what does the tumor look like, you should ask which stage or pattern of the liver does it actually look like. So, for example, sometimes it can look like a fetal liver, sometimes it can look like an embryonal type of liver, sometimes it can look like a small round blue cell tumor. So basically the pattern is of a recapitulation of the liver development. Clinically, hepatoblastoma is strongly associated with a young age at presentation, and also approximately, let's say 85 to 88% of the cases occur in children roughly around the age of 19 months, just like the case I have shown you, which was of a 2-year-old child. So then we move on to the epidemiology. The age distribution is primarily the first clue when you're talking about a hepatoblastoma, because most, like I told you, roughly 85 to 88% occur in a children below 5 years of age, which is roughly only about 4 to, when you come and look at a child about 15 years of age, if the presentation happens, that occurs only in roughly 2 to 3% of the cases. So the mean age at diagnosis is about 19 months, and also there is a slightly male preponderance in the tumor, and the incidence is higher among the low birth weight infants. And there is an increased incidence that is partly related to the survival of these low birth weight infants. So whether you encounter a liver mass in a very young child, hepatoblastoma should immediately be in our differential diagnosis whenever you encounter a young child having a liver mass. The clinical presentation by far is always of a brainless abdominal mass that is slowly growing. And the laboratory finding that immediately attracts our attention is alpha-fetoprotein. The alpha-fetoprotein is elevated in roughly about 75 to 95% of the cases, and it reaches extremely high levels. It is not going to be borderline elevation at all. It exceeds about 1 million nanograms per ml. Importantly, alpha-fetoprotein is not simply a diagnostic marker, it is also a prognostic marker. During the follow-up to assess the response and subsequently to help detect a recurrence also, alpha-fetoprotein remains an important marker for hepatoblastoma. However, there is one important pediatric caveat. AFP is also physiologically elevated during infancy. So that is why I'm telling you that especially during the first 6 months after birth, So an elevated AFP in a very, very young infant should not be equated to hepatoblastoma. Only in an age beyond 6 months of age, when it is very, very high, that is when you're suspecting a hepatoblastoma. And there is a coexisting presentation of a hepatomegaly, which is very slowly growing mass and a painless abdominal mass. Okay. So if you look at the pathogenesis, the major molecular pathway involved in hepatoblastoma is the molecular alteration that involves CTNNB1, which encodes for the beta-catenin pathway. Approximately 90% of the hepatoblastoma are seen associated with the CTNNB1 mutation, and the consequence of this abnormality is the beta-catenin signaling defect and accumulation of beta-catenin in the nucleus. This molecular biology is directly relevant in pathology because it gives us a useful immunohistochemical clue. In normal hepatocytes, the beta-catenin is predominantly membranous, while in hepatoblastoma, the abnormal nuclear and sometimes the cytoplasmic staining can be seen. There is also an association with germline APC mutations of familial adenomatous polyposis. So the WNT beta-catenin pathway is one of the most important concepts to remember in hepatoblastoma. Hepatoblastoma can occur as a part of several genetic and congenital syndromes. The important associations include familial adenomatous polyposis. It includes Beckwith-Wiedemann syndrome. It includes Li-Frombini, Simpson-Galloway-Bemmel syndrome, SOTA syndrome, Kabuki syndrome, and Prader-Willi. So there are multiple familial associations in hepatoblastoma. Other reported associations include those of trisomy 18, glycogen storage disorders, hemihypertrophy, and for examination purposes, it is also important to remember that there is an association with the APC and familial adenomatous polyposis because APC is linked to the WNT beta-catenin pathway. So that is an important caveat that you have to remember. Radiologically, hepatoblastoma usually presents as a solitary or multifocal heterogeneous intravascular liver mass. Calcification is also common. Imaging is not merely used to identify the tumor, but it is essential for determining whether the tumor can be surgically resected or no. We need to know that many liver segments are involved, and how many are involved is what you want to look at in the radiology. And if there is any extrahepatic disease association, that is also something very important that you have to look at while talking about the hepatoblastoma. So this forms the basis of what I was talking to you about as a pre-test system, which we will discuss later on in this presentation. Therefore, hepatoblastoma, the pathology and radiology are very, very closely linked. And with both of them in conjunction only, the clinician will be able to treat this disorder. So the histological diagnosis and prognosis is both on histology and radiology. Grossly, if you see, are you able to see the tumor in this liver? So this is the area where you're seeing an area which is showing hepatoblastoma. So gross examination can provide some important clues of the underlying histology. So usually these tumors exceed 15 centimeters in size. The tumors can be solitary or they can be multifocal. They can be lobulated or they can be vaguely heterogeneous. Areas showing fetal differentiation may resemble the normal liver too. Embryonal and small cell areas tend to be slightly softer, more fleshy, and they can be gray tan in appearance, while the mesenchymal areas will be slightly firmer depending on the component of the mesenchyme. Suppose it's a bone or a cartilage, then it will be much more firmer. If there is osteoid, you can see some calcified material also on gross section itself. The particularly striking appearance can occur in a teratoid or in melanotic component because there will be dark brown pigmentation associated with this component. And grossing is extremely important because that will help you identify the components and also if there is any vascular invasion. Histologically, the hepatoblastoma is best understood by dividing these into epithelial, mesenchymal, and teratoid elements. These help understand the patterns as well. The epithelial component includes the fetal and the embryonal patterns, and there are several other patterns that are recognized, like the small cell undifferentiated, cholangioblastic, macrotrabecular, and mixed patterns. The mesenchymal has usually a primitive spindle cell type of a pattern of mature fibrous tissue, but they can be osteoid, bone, cartilage, rhabdomyoblast, etc. If you look at a teratoid, the presence of the neural tube or neuroectodermal element is what is consistent with the teratoid type of a change. And some mixed patterns can have neuroglia, ganglion cells, and melanin pigment as well. So this is the fetal pattern of hepatoblastoma. So you're able to see here that there are so many uniform polygonal cells. So these polygonal cells are characteristic of a fetal type of hepatoblastoma, where you have these uniform type of polygonal cells. So this is the most important microscopic pattern of hepatoblastoma, in which the cells are relatively uniform and polygonal, and they are smaller than the normal hepatocytes. And they have a round to oval nuclei with inconspicuous nucleoli. You can't see the nucleolus very clearly here, isn't it? So the round to oval nuclei characteristically is placed in these polygonal cells, which are appearing to be clear. And they use, sometimes if they can appear eosinophilic, but they do not have characteristically prominent nucleoli at all. One characteristic feature is the presence of alternating dark and light areas. So if you're able to see, there are some dark areas here and some light areas here, isn't it? Some dark, some light areas. So that is a characteristic presence of some dark and light areas that are seen in the fetal type of hepatoblastoma. That's a characteristic finding. That basically represents the variable quantity of glycogen within these cells. Whether it is less or more is the color that is associated with it. The cells form somewhat cords or trabeculae in the whole thing. And important is that the pure fetal histology is associated with a very, very favorable prognosis. So if you have completely this type of a pattern in the hepatoblastoma, you should be happy. This is also important that in that entire tumor should show a fetal type of histology to call it a good prognosis. And the mitotic activity is 2 or fewer mitosis per hyperfield usually, per 10 hyperfields usually. And the tumor can be classified as a pure fetal type. Pure fetal type of hepatoblastoma is associated with an excellent outcome, and also stage 1 hepatoblastoma of pure fetal can be completely surgically cured. Therefore, recognizing this is having a very good clinical relevance. Then moving on to crowded fetal, I wanted to look at this pattern. Both of these areas, both of the halves of this image are having pure fetal only. But this is the one on the right is crowded. This is called a crowded fetal pattern. So the crowded fetal pattern is closely related to the conventional fetal pattern. The cells remain the fetal type, but they are more closely packed. And they show more mitotic activity. The important numerical distinction is that the crowded fetal has more than 2 mitosis per 10 hyperfield, while the normal fetal has less than 2. So there also is a slight increase in the nuclear cytoplasmic ratio. If you see, the cells are looking slightly larger and the nuclear cytoplasmic ratio is more, and the nuclei are appearing slightly larger than the counterpart on the left, isn't it? So the practical difficulty is that the crowded fetal areas can merge into the embryonal areas. So the distinction may sometimes be very challenging. This is one of the reasons why hepatoblastoma should be assessed along the multiple sections, and multiple sections should be taken before you actually tell which type of material is there in what ratio. So that has a practical relevance. So that is the reason why you have to know this type of pattern as well. So now moving on to the next pattern. The next pattern is the embryonal pattern. The embryonal pattern is the most common epithelial pattern in hepatoblastoma. Compared to the fetal cells, the embryonal cells are more primitive and they tend to occur in sheets, but can also form pseudo-rosettes. So if you're seeing there are so many pseudo-rosettes, even the one that I had shown you, there was embryonal and fetal both of them were there. So they can be acini, they can be tubules. The nucleus are somewhat angulated and they have relatively coarse chromatin. If you see, compare it with the fetal, these cells are much larger. The nuclei are much larger. They're sort of squared off and they're relatively coarse, isn't it? So this is something that you can see in the embryonal pattern. The cytoplasm is kind of scant. The nuclear cytoplasmic ratio is much higher. And the mitotic activity is also generally higher than the pure fetal type of hepatoblastoma. One of the most useful mental comparisons is that fetal hepatoblastoma looks more like the developing hepatocytes, while the embryonal hepatoblastoma looks more primitive and can resemble a small round blue cell type of a tumor. Then if you differentiate the two, if you remember only one comparison from today's morphology section, remember the fetal versus embryonal section. The fetal cells are relatively differentiated. They are polygonal. They have abundant cytoplasm. They form cords and trabeculae like the image that I had shown you. The embryonal cells are far more primitive. They have less cytoplasm, more primitive nuclei, which are larger. They form sheets, acini tubules, and pseudorosettes. The fetal component may contain glycogen and lipid, producing a characteristic light-dark kind of appearance, like the band-like appearance that I had shown you some time ago. The embryonal cells are more likely to demonstrate an abnormal nuclear beta-catenin staining, that is Sometimes you can see both of these patterns hand in hand. Let me take your attention to the next pattern. If you're looking at this, this looks like a typical small round blue cell tumor. So this is a small cell undifferentiated pattern that is the most important adverse histologic pattern of hepatoblastoma. So these cells are extremely primitive and look like the small round blue cell tumor. The nuclei are hyperchromatic, they have high NC ratio, and they can be discohesive and infiltrative. So the diagnostic challenge is very obvious. When we see this pattern in the liver of a child, you have to consider a metastatic primary small round cell tumor, definitely, because most of the small round blue cell tumors love to sit in the liver. However, the cells of small cell undifferentiated hepatoblastoma can show nuclear beta-catenin. That is an important caveat you have to remember. Most importantly, the amount of the component should be reported. Even a small microscopic focus of this small cell undifferentiated pattern has to be reported because this is highly associated with a poor prognosis. If you see here in this image, you have a mixed pattern where you have this fetal polygonal cells on top. Take a look at these cells. These are fetal polygonal cells. Yes, the light band and the dark band is present in this image. And you have this undifferentiated small round blue cell tumor component. So definitely I would put my eyes on this and I will say there is an undifferentiated component. So I am not saying that the prognosis is going to be as good as just the pure fetal. This is going to be a bad prognosis in the child. So this is one of the most practical take-home messages for a surgical pathologist while examining a hepatoblastoma. Do not simply say embryonal pattern and move on. Actively look at all the sections and see and search for the small cell undifferentiated component. Even a very small focus should be documented because it has a very clear prognostic significance. And also it has an important molecular distinction from the malignant rhabdoid tumor. The small cell undifferentiated hepatoblastoma generally retains the SMARCB1, which is also called INI1 or BAF47. In contrast, the loss of the the SMARCB1 strongly raises the possibility of a malignant rhabdoid tumor. So the tumors with loss of SMARCB1 are now thought to be better classified as a malignant rhabdoid tumor rather than the small cell undifferentiated tumor. So if the important message, don't forget, if the SMARCB1 and INI1 are retained, it supports the hepatoblastoma diagnosis. But if with the same morphology there is a loss, then consider a differential of malignant rhabdoid type of etiology. Then moving to the macrotrabecular pattern, the macrotrabecular hepatoblastoma is particularly important because it can mimic the HCC. It very closely resembles a HCC. The tumor cells have broad trabeculae and the trabeculae can be several cells thick. It need not be only 2-3 cells, it can be several cells thick. So there are broad trabeculae and that can range from roughly about 4 to roughly 12 to 13 cells thick also. So when you have, there is an emphasis that the trabeculae generally is usually more than 10 cell thick that we encounter. So it is very important that you have to differentiate this from HCC, not based on architecture alone. So you have to carefully also look for other components of hepatoblastoma, which is a useful clue. So you can have a fetal and embryonal component in association. If you have that, it strongly supports hepatoblastoma over HCC diagnosis. But yes, IHC is also your choice for distinction. Then moving on to cholangioblastic pattern, if you see this image, you're seeing tubules. So you see small duct-like structures within and around the hepatocellular component. So that is a classical thing of cholangioblastic pattern. Although this pattern may create a cholangial kind of an impression, it should be interpreted in the overall context of the hepatoblastoma. So again, the diagnosis should be based on the combination of architecture that you have in the different sections and also on the cytology, rather than just the components and the type of ductular architecture. Okay, so this is also possible in hepatoblastoma. The hepatoblastoma is not always purely epithelial. You have to remember that you can have the mixed patterns where mixed hepatoblastoma may contain substantial amount of mesenchymal elements. Sometimes the mesenchymal elements are very, very high in percentage, where you see a very, very firm or hard type of a tumor. The mesenchymal component can range from highly cellular primitive spindle cells to relatively mature fibrous tissue. They can be also osteoid-like areas. And these are often even more because the mesenchymal reaction after chemotherapy is much higher. So post-treatment resection samples can have more of mesenchymal elements. Other heterologous elements, including bone cartilage or rhabdomyoblast, also can be seen in HCC. And the interesting point is that mesenchymal component can show immunoreactivity to cytokeratin and EMA, which strongly supports the relationship with the tumor rather than the anatomically indicating the undifferentiated sarcomas. So when you actually do these markers, cytokeratin and EMA, the EMA, it will actually tell you that this is a component of the hepatoblastoma and not a sarcoma. When both epithelial and the mesenchymal components are present, we describe the tumor actually as a mixed epithelial mesenchymal hepatoblastoma. And the epithelial component may contain fetal and embryonal elements, where the mesenchymal components, like I already told you, include spindle cells, which are primitive. It can have fibrous tissue, osteoid bone, cartilage, or rhabdomyoblasts. Some mixed hepatoblastomas have a teratoid feature. You call it teratoid only when there is primitive neuroglial tissue and ganglion elements and melanin pigment association. Other heterologous elements may include bone cartilage, rhabdomyoblasts that can be coexistingly present. They can be squamous cells, they can be mucinous glands. So they can be a mixed variable kind of a picture. So the hepatoblastoma and teratoid hepatoblastoma are important to differentiate. So basically, a mixed tumor is the image that I'm showing you, where there are squamoid nests, there are fibrostroma separating it, and there is also a neuroectodermal differentiation. So that is one thing that I have to tell you about. And also there are some chemotherapy related changes that you have to know. So hepatoblastomas, when treated with chemotherapy before a definitive resection, that can be done. So therefore, the pathologist should have an idea of what he's looking at when it's a post-treatment tumor. So after chemotherapy, presence of an osteoid-like element may become very prominent. And you may also encounter extensive fibrosis or treatment-related apoptosis here and there. And there can be necrotic areas also. The pleomorphic epithelial hepatoblastoma can be seen in post-therapy resections, and there can be bizarre pleomorphic cells with giant cell reaction also post-treatment after chemotherapy. So the interpretation of a post-treatment specimen requires the knowledge of what exactly chemotherapy does to the patient and to the tumor. So you should not look at it as a completely different tumor. It can still have giant cell reactions, bizarre pleomorphic cells, if it is a post-treatment resection after the initial chemo was given to the child. Beta-catenin has an importance in hepatoblastoma because it's the single most important immunohistochemical stain that you have to remember for hepatoblastoma. In normal hepatocytes, the beta-catenin is predominantly membranous. This is a contrasting image. You see on the top, you're able to see that there is a membranous positivity of this IHC. This is the normal hepatocyte. While at the bottom, the hepatoblastoma has this abnormal nuclear and cytoplasmic staining. You have the block positivity. So this is an important caveat where hepatoblastoma, you should remember that beta-catenin has abnormal nuclear and cytoplasmic staining that occurs because of the activation of the WNT beta-catenin pathway. And this is seen in approximately 90% of the hepatoblastomas, which show nuclear beta-catenin staining. Then the other IHC markers that are important is, one thing you have to remember, that beta-catenin alone should not be the only marker that you do for hepatoblastoma in isolation. You have to do glypican-3 and HEPAR1 also, which are positive in the fetal and embryonal type of epithelial components. And glutamine synthesis is particularly useful if it is strongly expressed in the fetal component and can be patchy in the embryonal component. So it is negative in the small cell undifferentiated component. Also INI1, which I already told you, you should consider loss of INI1 in malignant rhabdoid tumors, while it is retained in hepatoblastoma. In general, hepatoblastomas do not show INI1 loss. So in case you see SMARCB or INI1 loss, you have to reconsider your diagnosis and further do IHCs in terms of the rhabdoid type of architecture tumor and not a hepatoblastoma. So practical IHC approach for the hepatoblastoma, when I'm encountering a fetal, small child with a tumor in the liver, then I would first see if the tumor morphologically resembles a fetal or an embryonal pattern. So I would look for the embryonal and fetal differentiation as step 1. Then I would do a beta-catenin. That is particularly useful because nuclear staining supports the activation of the WNT pathway. Then I would do a glypican-3 and HEPAR1 that can support a hepatic differentiation. Glutamine synthesis that can help understand the epithelial component. And if the tumor has a small cell undifferentiated pattern, I would consider INI1 and SMARCB1 because its loss raises concern about malignant rhabdoid tumor rather than hepatoblastoma. So this is an algorithm that I would follow for IHC in case I encounter a pediatric tumor resembling a hepatoblastoma in a roughly 19-month-old child. So I wouldn't rely only on the morphology. The major differential diagnosis depends heavily on the morphological pattern. Fetal hepatoblastoma can be mistaken for a normal river in a young child, especially if it is roughly less than 6 months of age. Macrotrabecular and hepatoblastoma can resemble HCC very closely. Teratoid or mixed components can resemble a teratoma. The small cell undifferentiated hepatoblastoma resembles a metastatic neuroblastoma, peripheral neuroendocrine tumor, or a Wilms. Finally, in an older child over 8 years of age, hepatocellular neoplasms, NOS, becomes an important consideration. So everything depends on the pattern. It also depends on your age. So let's take one by one all of these differentiates. So the particularly important diagnostic problem is differentiating a fetal hepatoblastoma that can look surprisingly similar to a normal liver of a child. The tumor cells are generally smaller than the normal hepatocytes, but that is very difficult if a section is only having the tumor area. So we should look carefully to assess the architecture, compare the normal and the abnormal area. So you should have sections of normal versus abnormal where you can see crowding or fetal type of growth patterns. Beta-catenin is particularly helpful here. Nuclear and cytoplasmic beta-catenin staining, I had already shown you an IHC where the normal versus abnormal, where you have block positivity of both cytoplasm and the nucleus for beta-catenin is more suggestive of a hepatoblastoma. So the normal hepatocytes, like I said, has only a membranous staining. Glypican-3 again provides an additional support, and the distinction becomes particularly important at the edge of the tumor where hepatoblastoma blends with the normal adjacent liver. So these markers are very, very useful for you. Then hepatoblastoma versus HCC perhaps is the most important differential in an older child. So the problem is that the macrotrabecular type of hepatoblastoma, which I had shown you, very much resembles the HCC, like I already told you. So in these cases, the architecture alone is not diagnostic. The presence of both fetal and embryonal hepatoblastoma patterns strongly supports a hepatoblastoma rather than a HCC. But what if you don't have that pattern at all? Then you do again the same thing that you check the nuclear beta-catenin and glypican-3, which are more positive in hepatoblastoma. On the other hand, presence of nuclear inclusions, atypical mitosis, and alpha-1 antitrypsin globules, these favor HCC diagnosis. Age is also extremely important. A liver tumor presenting initially in a patient over 10 years of age is much more likely to be HCC rather than a hepatoblastoma. So when we consider the differential between the hepatoblastoma versus small round blue cell tumor, that is particularly important in the small cell undifferentiated type of pattern. The morphology of the tumor resembles a neuroblastoma or another small round blue cell tumor that has metastasized to the liver. The key is not to interpret the small cell component in isolation. We should search extensively to look for any components that are that show you conventional fetal or embryonal hepatoblastoma kind of pattern. The nuclear beta-catenin can be very useful, where glypican-3 and hepar-1 support the hepatic differentiation. Ultimately, the diagnosis depends on integrating the clinical setting, the imaging, the morphology, and the IHC in toto together. So we now look at the histology in staging. The pretext stands for pre-treatment extent of the disease, and this is radiological staging that people can give you on a CT, which is supported by sections of the corresponding areas by histology. It is primarily an anatomic system used to assess the extent of the liver involvement that helps to determine the surgical approach. The simplest way to determine this is to count how many contiguous liver sections remain free from the tumor. Pretext 1 means there are 3 contiguous sections that are tumor-free. Pretext 2 means there are 2 tumor sections that are free. Pretext 3 means only 1 contiguous section remains tumor-free. And pretext 4 means there is no contiguous segment that is tumor-free. So interpret pretext as the number increases and the extent of hepatic involvement increases. So this is also having a prognostic kind of a value. The pretext is supplemented by additional descriptors too. So V indicates the venous involvement, which means it is involving the vena cava. P indicates the portal venous involvement or the portal bifurcation. E indicates the extrahepatic extension and M indicates the metastasis. The C indicates the caudate lobe involvement. So useful memory aid is BPMC. So this is an additional caveat that they would tell you in addition to the pretext staging. The COG staging or the children oncology group staging is a different perspective from the pretext. Pretext is an anatomical pretreatment classification, while the COG staging incorporates the extent and the surgical resection and residual disease presence. The stage 1 means the tumor has been completely resected with negative margins. The stage 2 means the tumor has been grossly resected, but the microscopic residual disease is there, in the sense on the frozen section, you are seeing some positive margins. The stage 3 is unresectable disease or biopsy-only disease, where macroscopic residual tumor is present and the tumor rupture and positive abdominal lymph nodes are present. And stage 4 indicates distant metastasis, such as lung or other distant organ involvement. So it basically is the staging on surgery. Approximately 10 to 20% of the patients have a metastatic disease at presentation, unfortunately. The lung is by far the most frequent site. However, the metastasis may occur in bone, brain, eye, or ovary. And the presence of metastasis at diagnosis is one of the major adverse prognostic factors. That is where staging is not simply a classification exercise. It is also something that influences the prognosis and planning of the treatment for the patient. So if you look at the prognostic factors, complete resection is associated with an excellent event-free survival, whereas an unresectable disease is significantly poor outcome. Pure fetal hepatoblastoma has an excellent prognosis, while the presence of small cell undifferentiated component is associated with an adverse outcome. Pretext 4 disease, large tumor, vascular invasion, metastatic disease, these are all again negative, poor prognosis markers and poor response to chemo as well. Interestingly, very low alpha-fetoprotein at presentation can also be an adverse prognostic factor. That is also an indicator because hepatoblastoma are known to produce AFPs. Usually AFP, if it is reduced, it means the good histological pattern is less. The treatment of hepatoblastoma is based on a combination of surgery and chemotherapy. Surgical resection is the definitive treatment. Whenever possible, complete resection is to be done. However, only approximately 1/3 to 1/2 of the patient have a resectable disease at presentation. The preoperative chemotherapy can convert more than half of the initially inoperable tumors into a resectable tumor. It is also that COG standard regimens, such as what is used is actually cisplatin, 5-fluorouracil, and vincristine, which is C5V regimen. That is the usual chemotherapy regimen that is given to these patients. And liver transplantation can be considered in selective patients who have unresectable bad tumors. So in a pathology point of view, when reporting hepatoblastoma, we should have a systematic approach. First, identify and describe the epithelial pattern available. If the fetal morphology is present, determine whether it is truly pure fetal. Secondly, look very actively among all different sections to look for the small cell undifferentiated component and report its presence without fail. Third is document the mesenchymal and teratoid elements if present. Then assess the surgical specimen for vascular invasion, treatment effect, and margin status. Finally, integrate the pathological findings and radiological staging. And a good pathology report should not simply say hepatoblastoma. It should communicate the features which actually affect the prognosis and the management. So thank you so much for your attention today. Don't forget to follow www.drdeepaslearninglaunch.com for more such videos. I will again share another case and then come up with a video soon. This is Dr. Deepa signing off. Bye-bye.